Okay, well, I have to tell you all about our medical school again. No, I just briefly wanted to say that I'm Julie Byerly, and it's my pleasure and honor to be the president of Geisinger Geisinger College of Health Sciences and the dean of the Geisinger Commonwealth School of Medicine. And our school was founded, to produce a health profession workforce for the region. We've got 1,000 physician graduates, about 2/3 of them still in training. And we already have almost 50 physicians in the region serving our communities already, thanks to the support of the Abigail Geisinger Scholars Program that Geisinger as a health system provides. We have 66 that are in training that are signed to come back to the area and work right here. And we've graduated 365 people training in primary care or practicing in primary care, and 69 who are training or practicing in psychiatry. So we believe that we are beginning, because medical education takes a long time, we're beginning to fulfill the dreams of our founders through the work of the school and make an impact on improving the health and well-being of our community. It's a pleasure to have our board chair here tonight, Virginia McGregor. Thank you for being here. One person we're missing tonight, but I want to certainly call him out, is one of our founders, Bob Naismith. Bob Naismith, as one of our founders, has really been a champion for preventive medicine, and he wanted to ensure that we have this ongoing preventive medicine lectureship. Some of you have attended that year after year. We've offered it many years in a row. But for some of you, it's new, and I want you to know that you are welcome here. We're so glad to have you here, and one of the goals of our professorship in preventive medicine is to inspire the community into healthful habits and healthful eating. So tonight it's our pleasure to advance this effort through the Preventative Medicine Lecture Series of 2024. And we're so excited to have with us Dr. Sarai Stancic. And I'll tell you just a little bit about Dr. Stancic. She holds triple board certification. Remember I told you medical education takes a long time. I'm sure it took her quite a long time to get through medical school, which she did at the University for Medicine and Dentistry in New Jersey. And then she trained in first infectious diseases, where she also served as chief of infectious diseases in the Hudson Valley VA in New York. And then subsequently, she shifted her focus, I'm sure she'll tell us some of that story, into lifestyle medicine. I know part of that story was driven by her own personal experiences of illness and then health, and she'll share some of that with us. Over the past couple of decades, she has championed preventive and lifestyle medicine on a global scale, advocating for change in physician training, and she's helping us with that today. Dr. Stancic is also the producer and co-creator of the documentary film called Code Blue, and she's author of the book, What is Missing from Medicine: 6 Lifestyle Changes to Overcome Chronic Illnesses. So please join me in welcoming Dr. Stancic. We're so glad to have you here with us tonight, and we look forward to your work tonight.
Thank you so much for that lovely introduction. My mic is working? We're good? Can you hear me?
Yes,
Thank you so much for that lovely introduction. It is a great honor to be here. I do want to take a moment to thank Bob Naismith. I know he's not here today, but thank you so much for bringing this preventive medicine series to Geisinger and for inviting me. It's truly an honor. I always like to begin my presentations with a personal introduction. I have somewhat of a challenging name, so we'll start there. My name is Sarai Stancic, and I have been a physician for 30 years. By training, I am an internist and an infectious disease specialist, a field I became deeply interested in as a young medical student. You see, I went to medical school in Newark, New Jersey in the late 80s and early 90s, and regrettably, that period was coincident with the height of the HIV/AIDS epidemic. And as you might imagine, within that experience, I witnessed unspeakable human suffering and loss, and I wanted to be part of that solution. So when I completed my chief resident year in internal medicine, I went on to a fellowship in infectious diseases. Now, it's really important for me to say this. I'm very proud of the work that I did in the field of infectious diseases over more than 15 years, not only in patient care, but also in research and helping to develop better treatments for those affected. But today, I no longer practice infectious diseases. Today, I am a passionate advocate and champion for a discipline we call lifestyle medicine. Now, lifestyle medicine, for those of you who are not familiar, is a relatively new discipline whose focus it is to educate and empower patients on the importance of optimal nutrition, physical activity, stress management, effective sleep hygiene, addressing issues of substance abuse like alcohol and tobacco, and then recognizing the importance of interpersonal relationships and the role that they play in maintaining health and well-being. Now, why is all of this so important? It's important because when we optimize these aspects of lifestyle, we can indeed prevent nearly 80% of chronic disease. Isn't that amazing? But the logical question you may have for me is, how does an infectious disease specialist with the background that I just described to you evolve into a passionate advocate and practitioner of lifestyle medicine? Now, in order for me to effectively answer that question, I need to share with you two separate experiences that occurred in my life who have shaped who I am today. One of them is a personal experience, and the other is a professional one. I'd like to begin with my personal story. And for that, I'm going to take you back to October 11th, 1995. On this day, I was on call at Beth Israel Medical Center, and it was a really, really busy night. One of those nights where your pager just doesn't stop ringing. I was literally running from the ICU to the emergency room and back to the general ward all night. And it wasn't until sometime in the mid-morning hours where I finally found that opportunity to make it back to my on-call room. I remember making my way there and feeling so deeply fatigued, something I had never experienced before. The minute my head hit that pillow, lights out. Shortly thereafter, as you might imagine, in the midst of that very busy call, I was just paged again to address another urgent matter. But this time, when I tried to get up out of that sleeping position, an extraordinary thing happened. I couldn't feel my legs. I remember reaching down to touch them, and they felt as if they were someone else's. Panic set in, and next thing I knew, I was in the emergency room undergoing an MRI of my brain and spinal cord. And those studies confirmed a diagnosis of multiple sclerosis with multiple lesions in both my brain and spinal cord. And so just like that, everything changed. I was no longer that young, healthy, vibrant physician, at least I thought I was, that had walked through those hospital doors earlier that morning. I was now a chronic illness patient, and I myself was admitted to the hospital. And with that came what I call the era of drug dependency as the parade of pharmaceuticals marched into my life. I was immediately started on IV steroids to treat that acute event, and then multiple medicines to treat my now failing bladder, peripheral neuropathy, spasticity, and pain. I was discharged after 5 days and told to come back in a week because it was then that I would start what my doctors referred to as the DMT, or disease-modifying therapy. They told me this was the key to slowing the progression of this chronic neurologic disabling disorder, and without it, I'd likely be in a wheelchair within 10 to 20 years. I can tell you those are difficult words to hear when you're 28 years old. Of course, I was going to do whatever my doctors asked of me. So I returned a week later. My doctor sat me down and he said, Sarai, I want you to know that this treatment is quite effective, but it's not going to be easy. This is a drug you're going to have to inject every day. And I said, for how long? And he said, for the rest of your life. He said, this is a drug that has a significant side effect profile that includes fever, chills, muscle aches and pains, nausea, vomiting, diarrhea, anorexia, insomnia, depression, and suicidal thoughts, to name a few. But he said, don't worry, because I know exactly what to do to reduce the likelihood that you'll ever experience any of those side effects. So my ears perked up. He said, you're going to do two things. 30 minutes before you inject this drug, you're going to pre-medicate with either Tylenol or ibuprofen. And secondly, and most importantly, you're going to inject the drug right before you go to bed. This way, you'll sleep through all the side effects. Ladies and gentlemen, I can tell you that not once did I sleep through those side effects. I would inject the drug at 10 o'clock at night, and at 2 o'clock in the morning, I would awaken with violent shaking, chills, fever, et cetera, et cetera. After doing this for a couple of weeks, I didn't think I could do it much longer. I picked up the phone to let him know I'm calling it quits. But before I could get a word in edgewise, he said to me, this is not an option. You have to stay on this medication. And he reminded me of that wheelchair in case I had forgotten. He said, look, I know it's hard, but what we'll do is we'll treat the side effects of this drug with other drugs. So when I couldn't sleep at night, I was given a prescription for Ambien. When I couldn't wake up in the morning, I was given a prescription for Provigil, an amphetamine-like drug. And when I became depressed because my life was unraveling, I was given a prescription for Prozac. By the time I was in my early 30s, I had snowballed into this chronic illness patient dependent on nearly a dozen drugs to get through a typical day. And despite all of these medications, my disease progressed and my quality of life suffered immensely. 8 years into the diagnosis, I was largely dependent on a cane or set of crutches. And to be frank, I began to lose hope. And then, when it appeared to be my darkest moment, came some light. And I call this my aha moment, that sudden moment of awareness. And it came in the oddest of ways. At this point, it's 2003. I'm chief of infectious diseases at the VA in New York. And I'm sitting in my office doing paperwork. And my secretary walked in to drop off the Daily Mail, as she would every day. But on this day, she drops this big stack on my desk. It catches my attention. I look over, and on top of the stack, I see a journal. And on the cover of the journal, I see the words multiple sclerosis, and of all things, blueberries. And I think to myself, what in the world could blueberries have to do with multiple sclerosis? So I drop everything, I turn to the article, and of course I find an unscientific, poorly constructed study that essentially took a small group of MS patients, fed them a diet rich in blueberries, and this author has the audacity to conclude that the patients who ate the blueberries felt better. Not a very objective clinical endpoint. I was a scientist. I couldn't believe anyone had conducted such a study and that it had been published. I had lunch with a colleague of mine that afternoon. I told him about it. He laughed, and so did I. But there was something about this silly little blueberry study that I couldn't get out of my head. And it wasn't that I thought eating blueberries was going to solve my problems. A much more important question surfaced from this line of thinking. For the first time in my adult life, as a dual board-certified attending physician, I considered the following question. Could there be a connection between diet and disease? Now, if anybody could answer that question, you'd think I'd be able to, right? I was a physician. 4 years of medical school, another 4 years as an internal medicine resident, and another 2 as a fellow. That was 10 years. A decade of my life dedicated to higher education in the field of medicine, and yet I couldn't think of any examples in which one of my professors, mentors, or educators ever connected those 2 dots. But I remained curious, maybe because I was desperate. I decided to look into this myself. So I turned to the scientific literature. I went to PubMed and I typed in words like multiple sclerosis and diet, chronic disease and diet. And what I got back was nothing short of remarkable. And this was one of the first studies I came across, published in the New England Journal of Medicine in 1952, more than 70 years ago, by this gentleman, Dr. Roy Swank. And in this publication, Dr. Swank writes about the incidence of MS in Norway, which, by the way, has one of the highest rates of MS in the world. But as he drills down and he looks at the specifics of what's happening in Norway, he notes that the highest concentrations are occurring in the inner farming community, where they're consuming a lot of dairy, animal sources, a lot of saturated fat, as compared to those who are living on the coast that are eating primarily vegetables and fish. And so he hypothesized that somehow saturated fat was playing a role in the evolution of this disorder. Now, he didn't just leave it at hypothesis. He actually started treating patients with a low-fat, primarily plant-based diet in the 1950s and followed a cohort of 264 patients for 20 years and then published his findings in the Archives of Neurology in 1970. But he didn't stop there. He followed them an additional 14 years, ultimately published his data in the Lancet journal in 1990. And so what did Dr. Swank conclude after following these patients over 34 years? Those who adhered to the diet showed significantly less disability and lower mortality rates. Of those that survived, 95% remained physically active. Those words, 95% remained physically active, jumped off the page. I couldn't believe it. I was excited to see this. I mean, this offered me some hope. Every time I saw my doctor, he talked about the wheelchair that was inevitably in my future. And it wasn't just Swank. There were several other publications, Canadian studies, European studies, that aligned with this thinking. And there were other variables that were important, like diet, beyond diet, exercise, smoking, weight. I was curious to know how it was that I had never learned this before, and why was it that my doctor, who was an MS expert, had never talked to me about it. I was excited to share this with him, so I made copies of all of these articles that I had seemingly uncovered, highlighted all the excerpts that I thought were important, and off I went to meet with him. I shared all this information. He sat across the room from me, looked somewhat puzzled. Towards the end of the conversation, he walked over, put his hand on my shoulder, and he said, "Sarai, do you really think that changing your diet or any of these other aspects of your lifestyle is really going to make a meaningful change in your outcomes? It is not. I know this is not what you want to hear, but what you need to do is remain compliant with the medications as prescribed. And if you want to blame anything for MS, you can blame your genes, because that's why you have MS, and there's nothing you can do about that." And then he politely escorted me out the door. As you might imagine, I felt quite deflated when I left this visit. But not for long, because I started to think more and more about my doctor's parting words, "It's your genes." And it brought me back to an experience I had as an undergraduate at Rutgers University when I took a genetics course. And I recalled the professor one afternoon excitedly lecturing on monozygotic twins. And monozygotic twins are really very interesting from a geneticist perspective because you have two separate individuals that have the same genetic material, and you can learn a lot from that example. So I pondered the following question. What is the likelihood, if twin A has MS, what is the likelihood that twin B would have MS? That's what we refer to as concordance rates. So had anyone looked and answered that question, again, looked into the scientific literature, and of course someone had, and it wasn't 100% as my doctor might have suggested, it wasn't even 50%, it was 14 to 33%. So what did this tell me? This told me that it wasn't just my genes, that there were indeed other variables that were contributing to the manifestation of this disorder. So that hope I had lost began to seep back in. Again, I turned to the scientific literature looking for answers, and that's when I came across the science of epigenetics. First described in the 1950s, but really flourished in the 1980s. And epigenetics essentially tells us that gene expression is dependent on outside variables. That is, just because you have a genetic predisposition to a particular disorder doesn't necessarily mean that it will be expressed. So what are those variables that epigenetics tell us are so important? Are you ready for this? It's things like diet and nutrition, exercise, stress, smoking. Sounds a whole lot like lifestyle medicine, doesn't it? Yeah. And I love this image because it so beautifully captures epigenetics. We have this gentleman in the center of the slide, and on either side of him, two very distinct sets of decisions. On one side, we see an outdoorsman. He's out there getting sunlight, vitamin D. He's consuming a lot of whole plant-based foods rich in antioxidants, phytonutrients. He's active. completely different story on the other end. We see a couch potato, the curtains are drawn, the television is roaring, and he's consuming a lot of highly processed junk food. And we can see that his decisions have led to very distinct external appearances. But we could also appreciate what he might look like on the inside, like what the intima of his coronary arteries might look like. Of course, genes play a role. No one is debating that. But don't let anyone convince you otherwise. Lifestyle matters most. At some point, I was convinced there was a mountain of scientific evidence before me, and I couldn't ignore it. I was convinced that I needed to implement changes in my own life. So I made the decision, it wasn't a popular decision, but I was going to taper off of every one of those medications on which I had grown dependent, and I was going to optimize every aspect of my lifestyle. So I began this journey in 2003. The first thing I did was I changed my diet. I adopted a whole food plant-based diet rich in whole grains, fruits, vegetables, legumes, nuts, and seeds. Exercise. At this point in my life, I could do very little. Poor balance, very weak. I was walking with a cane or a walker. And so the only thing I could do is to get onto a stationary bike, supported by my husband. I could do a minute or two, and then exhausted and in pain, he would carry me off. It would take 20 minutes to recover from that. But the next day, I'd get back on, and the day after that, and the day after that. And over time, I built stamina, strength, and endurance. Stress. I brought my team together at the VA, and I let them know that I wasn't going to take on that extra research project. I wasn't going to take on that extra clinic block. I was going to delegate that. And I was going to leave at 5 o'clock every day unless there was a patient emergency. For the first time in my life, I was putting myself first. Sleep. Sleep was one of the hardest hurdles for me because I was addicted to hypnotics like Ambien and benzodiazepines like Ativan, which my doctors freely prescribed and encouraged me to take. So tapering off that medication was a huge challenge. And then I studied sleep physiology, understood the importance of the environment, of pre-sleep rituals, and I learned how to sleep on my own organically, and it changed my life. And you know what happened? It didn't happen in a week, and it didn't happen in a month, but I started to feel better. At first, it was something as subtle as I could stay up past Jeopardy. One afternoon, I got to work, and I felt confident enough to leave the cane in the car. I'm often asked, how long did it take before you really knew that these changes you had made were really helping you? And it's hard to say. But I do remember one day, and it's about 2 years into my lifestyle change, and I happen to have a photograph of that day. It's July 2nd, 2005. The reason I have a photograph is because on this day, my friend Tim was married, and he invited my husband and I to his wedding. And on this day, I did two things that I thought I would never be able to do again. And it's going to sound very trivial to you, but to me, it was a big deal. I wore heels, and I danced with my husband. Around this time, my brother came to visit me from LA. Now, he lives in LA. I live in New Jersey, so we're on opposite ends of the country. We don't get to see each other very often. But he was so happy to see his sister back, free of the cane, joyful, happy, hopeful. He also had some good news for me. He had recently run the Los Angeles Marathon, and he was so excited to share his photographs at the finish line and how accomplished he felt at arriving at this goal. Towards the end of that conversation, he looked at me and he said, I know you're going to think I'm crazy, but I think you should run a marathon. And I shot him a look. Are you crazy? I can't run a marathon. I have multiple sclerosis. And I thank my brother almost every day for that, because in that moment, the way I responded, almost angrily, I realized in that moment that I was living my life first and foremost as this woman with MS, this doctor with MS, this mother with MS. And with that label came so many limitations, things I could do and things I couldn't do. And I realized I needed to let go, release that designation. My brother made his way back to Los Angeles, but he had planted this seed. And so without really telling anybody, I tried to go out and do a little bit of running. Didn't go so well. Fall, scrape my knee, but heal up and try again. There's this little nature preserve right down the street from where I live. Of all things, it's called the Celery Farm. I spend a lot of time here. It's not very big. There's a little body of water in the center. If you make it the entire way around, it's about 1.1 miles on that path. The very first time I made it the entire way around without falling or stopping, I felt invincible, like, Rocky at the top of the stairs, invincible. I called my husband. I said, honey, I don't know how and I don't know when, but someday I'm going to run that marathon. And I'm happy to share that on May 2nd, 2010, I did cross the finish line at the New Jersey Marathon, and it was an extraordinary moment for me, not because I ran a marathon, but in that moment, I realized that all of these changes, all of this investment in my health and well-being and had borne fruit. And today, it's been almost 29 years since my diagnosis, and I remain medication-free and still standing on my own 2 feet. I thank you. Thank you for allowing me to share my personal story. At the start of this presentation, I said there were 2 parts to what have made me who I am today. The second, of course, my professional experience. And for that, again, began my career in the field of infectious diseases, and just like any other physician practicing medicine across the country, managing many of these common diseases that we see on the CDC's top 10 causes of death. It's no surprise to learn that heart disease and cancer are the top leading causes of death. In fact, those 2 alone account for 50% of all deaths. But we see other lifestyle-related diseases on this list, including stroke, Alzheimer's disease, diabetes. Diabetes is a disease that is exploding in our country. We currently have about 12% of Americans living with diabetes. And the CDC ominously predicts that by 2050, 30% of Americans will be living with diabetes. I can tell you that our healthcare system cannot support that. It will implode. We cannot continue on this trajectory. Let me show you what diabetes looks like when you're an infectious disease specialist. This is a common consult that I would get at the VA. It's an infected diabetic foot ulcer, and the question to me would be, Dr. Stancic, what antibiotic should this patient be placed on and for how long? And I would examine these patients and often find bone involvement, which is what we call osteomyelitis. Very difficult infection to treat in anyone, but especially in diabetics because they have poor vasculature. So even when we do all the right things, when we debride these effectively and we place the patients on the right antibiotic, it's not uncommon for a patient like this to end up like that. So now you have a poorly controlled diabetic status post-amputation. Do you think this patient is going to sign up for a 5K? No. They're going to be more sedentary, blood sugars further out of control, blood pressure further out of control, increased weight, and that sets them up for the next catastrophic event, the heart attack or stroke. And now the infectious disease physician is being called in to help manage the ventilator-associated pneumonia. This scenario that I just described to you is not unique to me. It happens every day in every hospital across our country, and no one bats an eye because this has become very normalized. But this is unacceptable to me because I know that diabetes is largely preventable. And that's not my opinion. That's what the scientific evidence tells us. An example of that is the Potsdam study. This was conducted in Potsdam, Germany. Large prospective study in more than 23,000 participants. And in this study, the investigators wanted to understand what type of benefit one reaps when you adhere to 4 healthy lifestyle factors. And so what were those 4 healthy lifestyle factors? Number 1, eating a healthy diet, one rich in fruits, vegetables, whole grains. Number 2, not smoking. Smoking, of course, the worst habit in which you could engage. Exercise. Not asking much here, about 30 minutes of exercise, a 30-minute walk every day, and then finally maintaining a healthy weight. Those participants that adhere to those 4 healthy lifestyle behaviors could expect a near 80% lower risk of developing a chronic disease. But if you look at the specifics under that overarching 80%, 81% of heart attacks were prevented. This is the #1 cause of death in the United States. We lose nearly 700,000 Americans each year to heart disease. We know how to prevent 81% of it. Strokes are cut in half. Malignancies, a third of malignancies could be prevented. And here's the headliner: diabetes, 93% preventable. This is a disease I just told you is growing near exponentially. We're in trouble in our country. 1 in every 2 of us is living with at least one chronic disease. We're spending $4.1 trillion in healthcare each year in the United States, and 90% of those dollars are allotted to the management of chronic diseases, 80% of which we know how to prevent. You're probably familiar with the CDC's obesity maps. This is the behavioral risk factor surveillance system. Every year since 1985, the CDC puts out a map looking at obesity rates across the country. Currently, we have 42% overall obesity rate. But just to give you a sense, since 1985, every year it's worse. And just to give you a period to look at, in early 2020, I was offered an opportunity to write a book. And I started writing it in January of 2020. And the first section that I looked at to write was the obesity section. So I went to the CDC website to see what the rates were and to look at this obesity map. And I noted that there were 5 states at the time that had obesity rates greater than 35%. And I wrote that within the text of the book. 10 months later, I completed the book and I went back for final edits and to check my references before the book went to print. When I went back to the CDC to check, it was no longer 5 states, it was now 9 states. And that's what I included in the book. This is the most recent map. We now have 22 states, those are depicted by red, with obesity rates greater than 35%. So that's just how quickly this is improving, rather worsening. And you can expect the next map will come out in September of 2024. Get ready for it. I can almost predict we'll have more than 22 states, I hope I'm wrong, more than 22 states with obesity rates greater than 35%. We've known for some time what are the root causes of this obesity, diabetes, chronic disease epidemic. In this seminal paper by McGinnis and Faggy, entitled Actual Causes of Death in the United States, these scientists looked at a large volume of data over nearly 20 years to distill out what were the root causes. And here's what they found. The leading contributors to premature death in 1990 were #1, smoking. No surprise there, the worst habit in which you could engage. But look at what #2 was, our poor diet. Now, interestingly, McGinnis decided to revisit this 20 years later. So now we're going to 2010. And what did he find? Our diet had now surpassed tobacco as the leading contributor to premature death. And that's where we are today. It's such a profound statement, it merits its own slide. Diet is the most important factor contributing to premature death. We are literally killing ourselves with our forks. It would make common sense that the #1 contributor to premature death, the #1 killer amongst us, that physicians would be highly skilled in understanding how and why our diet is playing such a key and important role in our demise. So let's turn to nutrition education. Back in 1985, the federal government began to recognize that something is wrong. The American waistline is growing in the wrong direction. Chronic diseases are starting to increase. And so they recognized that this had something to do with our dietary choices. And so in 1985, the National Academies of Science said, we need to look at the state of affairs in our medical education system. We need to understand, what does nutrition education look like, because we're going to need doctors that are skilled in understanding these connections so that they can best manage their patients in the future. So they appointed a food and nutrition committee to look at this. And they did execute this, and they created a report that was presented to the US Congress. And here's what they concluded. Nutrition education programs in US medical schools are largely inadequate to meet the present and future demands of the medical profession. And look at the date stamp, October 1985. This was sounding the alarm. This was progressive thinking, and this was, regrettably, largely ignored. They threw money at it with very little accountability. And so today, 40 years later, we have physicians, in large part, that know little to nothing about nutrition. And why is that? In this wonderful paper written by David Eisenberg of Harvard, entitled Nutrition Education in an Era of Global Obesity and Diabetes, Dr. Eisenberg offers us an explanation as to why this is. The current medical education model, or he refers to it as an antiquated medical education model, is founded on this idea of pathogenesis. We teach our medical students to be expert at recognizing illness. We teach them the art of history taking and physical exam. We're collecting clues. Additional studies are done, imaging, blood work, again, collecting clues to create that differential diagnosis, make the diagnosis, and then our plan, our management plan, typically includes a pharmaceutical agent, a procedure, or a surgical intervention. And all of that is extraordinarily important. All physicians should be excellent at identifying disease and at managing and treating it and having the skill set and the armamentarium of pharmaceuticals available to them to manage a patient with a disease. But the problem with this is that that's only half of the human health continuum, right? Salutogenesis is the other half, the mirror image of pathogenesis. We don't teach anything about wellness, the maintenance of health and well-being. And that's what we're missing in our current medical education model. And so how do we correct this? How do we introduce salutogenesis into the medical training experience? And Dr. Eisenberg offers us how we might approach this. This is a quote from his article: future curricula would include modules on nutrition, exercise, sleep, mindfulness, self-care, and developing cutting-edge skills to support expertise in counseling patients on behavioral change. I just want to say a word about self-care, because physicians are not very good at caring for themselves, and I think that's something that should be part of the medical education experience. I was telling Dr. Byerly that at University of South Carolina, one of the things that they do when students first come in as first-year medical students is, you will be your first patient. Learn how to take care of yourself. Assure that they're healthy physically and mentally. We have one of the highest rates of depression and suicide in our profession. That is unacceptable. We represent health in our communities. We should be taking good care of ourselves, and we should be an example for our communities. We need to reimagine how we deliver health care, and the time is now. We can't arrive at that rate of 30% of Americans living with diabetes in 2050. We need to act now to assure that we prevent all of that morbidity and all of that mortality. Salutogenesis has to be the foundation of our healthcare system. Prevention must be primary. We need to value it. We need to teach the importance of all of these aspects of lifestyle. The American College of Lifestyle Medicine refers to the 6 pillars of lifestyle medicine, and I love that imagery because those pillars evoke strength. I like to use a wheel, and I took this image from my book, and the reason I like the wheel is because of the interconnectedness. So the spokes are the different aspects of lifestyle medicine. And the reason I use this with my patients and with a potential reader is because I want you to understand that wellness is interconnected. Some of us are just good at our diet, but then we don't exercise and we don't sleep effectively and we drink too much. It's important to address all aspects of lifestyle. Imagine that wheel, if one of those spokes was sort of wonky and not aligned with the others, your forward movement wouldn't be very effective. So to arrive at that sweet spot where you are your best self, you want to address all aspects of lifestyle almost simultaneously. The idea is here that we can all age gracefully, free of chronic disease. I want your last day on planet Earth to be a joyful one, surrounded by your family and friends. I want you to share a beautiful meal. I want you to dance, sing, whatever brings you joy. And then at the end of that glorious day, go to bed and pass away peacefully with dignity. Be the change that you wish to see in the world. I know you're familiar with this Gandhi quote. And in 2012, this struck me. I've been blessed in that here I am living with this chronic disease, once told that I'd be in a wheelchair within 10 years of my diagnosis, and that's not what happened to me. I felt empowered. I felt something, I learned something, and I wanted to share it with as many as I could. So in 2012, I made a decision that I was going to leave the field of infectious diseases, one that I loved, but I thought this was an important goal that I had in mind. I left my practice and I started one of the first lifestyle medicine practices in the country. So it's just internal medicine with an emphasis on prevention. I collaborated with an extraordinary clinical psychologist to help manifest behavioral change. I collaborated with a wonderful exercise physiologist and nurse and social worker. And we got to work and we supported patients in implementing change in their lives. And it was meaningful and exciting work. I went food shopping with my patients. We went walking and hiking together. We had support groups to support patients on this. It's hard to make lifestyle changes when you're 40 or 50 years old. You've been doing it all along. You need that community. You need that support. One of the most amazing things about this practice, and I could have never predicted it, at some point I realized that I had about 40 patients in my practice who were also doctors. And so how did that happen? It happened because at some point we had a patient in common. For example, a diabetic I was seeing went to see their endocrinologist, and their endocrinologist, wow, your blood sugars are so much better. Your hemoglobin A1C has gone from 9.7 to 6.2. How did that happen? Well, I've been seeing this lifestyle medicine doctor, and we're talking about diet, and we're talking about exercise, and we're talking about sleep, and it's really been helping me, and I feel great. And so that doctor would call me. What is this thing called lifestyle medicine? And then we would talk, and they'd say, well, I want to come see you. And I think at first it's just like, we'll have a cup of tea and we'll chat professionally. But no, I want to come see you as a patient because I'm struggling with X, Y, or Z, and I need your help. And it's been wonderful to help. I mean, every patient that I care for is an honor and a privilege, but when I have a patient who also is a doctor, that's amazing because as I help them, I know that in turn, that affects their entire patient panel. And that's pretty cool. The second thing that I wanted to do beyond my practice was reach as many people as possible. So whenever I could, I would do a podcast, write an article, do interviews, volunteer. I would call churches and libraries and ask them, can I come speak? And reach as many people as possible, share my story, and share the power that lies in lifestyle medicine. And then the final step that I took was I went back to my medical school, joined the faculty, and volunteered to teach this aspect of medicine to the next generation of medical students and next generation of our healthcare professionals. And that was wonderful. Here in this photo, this was taken in 2015. We were number 6. We were the 6th lifestyle medicine interest group to start. and this is our board, and this is our first meeting. The two students to my left are featured in Code Blue. If you've seen the film, you can see their stories, and they're currently now attending physicians doing extraordinary things in their part of the world, really acting to change the world. I'm so proud of them. They're like my children. I've been fortunate enough in that I've had an opportunity to visit all of these medical schools and share my work and share my story. It's been a personal goal of mine to visit every medical school across the country, and there's 192, so I have a lot of work to do. But I'm so happy that today I get to add this beautiful logo to my slide. And finally, I want to end the presentation with a word on the Hippocratic Oath. I know that you just recently had a commencement, and for those of you who don't know, the Hippocratic Oath is the oath that we take at the time that we graduate from medical school. And it is our commitment to our patient population to practice with the highest of ethics. It's a very special moment. I remember when I recited the Hippocratic Oath with my peers and colleagues when I graduated from medical school in 1993, and it was a very moving moment for me, for all of us, and to recite this in the presence of our family and friends who also made so many sacrifices to get us through medical school. The modern version of the Hippocratic Oath includes 347 words, but I submit to you that this excerpt of 13 are the most important. I will prevent disease whenever I can, for prevention is preferable to cure. And with that, I thank you for your attention.
Thank you so much, Dr. Stancic. We have a plant-based meal for all of us to enjoy together, but before we head out to do so, I'll invite some questions if anyone would like to come to a microphone and share a comment or a question.
Hello, Dr. Stancic, and thank you very much for a beautiful presentation. My name is Dr. Danish, and I've been in medical education for years now.
Yes, sir.
For almost 30, as much as you've been in medical side. And as you say, this is a trend, national trend of going and putting in more nutrition and preventive medicine, and establishing a preventive medicine association, international association. I have a good friend who's doing research in blue zones, so she's traveling all over the world as a part of that association. However, I just wanted to ask you one thing, is as we talk about the education, as the importance of teaching our young physicians and telling them to focus on the preventive aspect of medicine. One thing I think we might be missing in this issue, and I'm kind of interested in your point of this, is yes, we do teach them to learn more about nutrition, prevention, but we really are sending them into a very inefficient healthcare system.
Yeah.
So whatever we teach in a med school, we're sending them out there where they're driven by outcomes. So it means is the patient has high cholesterol, you give them a drug, cholesterol goes down, you see them in 6 months.
Yes.
With the preventive medicine, what I understand is that it will require much longer time, which is something that's really hard to sell to insurance companies and telling them, now I have to follow my patient for next, 6 years, because it takes time. Although I do agree with you that this is really the most efficient way to treat. So what is your opinion about it?
Oh, I mean, that's an incredibly important question, and yeah, that's the challenge, right? The reimbursement model. What I didn't tell you was that I did start this practice, but financially it was not beneficial for me. This was a sacrifice. This was something that I wanted to do because I was always told that patients are just not going to change. My cholesterol's up, just give me a pill, doc. And that's what colleagues say to me, that's not true. People want to feel well. If you give them the path, show them the way, and maybe you're not going to get all of them, but you're going to get some of them. The economics of this is complicated. There are really smart people, much higher pay grade than me, that understand this and are working on it. I know there's a physician, and now his name, Dexter Sherney is his name, who is the CMO at Blue Zones, and he's working on this. He's working with insurance companies to look at an economic model that can make this work. It's going to be hard, no doubt, but we have to figure out, there's a lot of brilliant people in this country. We all have to come together, sit at the table, and figure it out, because it's the health and well-being of our country. And what could be more important?
Thank you very much.
Thank you.
For sharing your story.
Do they teach nutrition in medical school now?
Very little. The average is about 19, this is from a publication, about 19 hours of nutrition education students are currently getting now, but it's primarily, vitamin deficiencies like scurvy and beriberi, so we're not really getting that. There are some medical schools in the past several years that are being, very proactive and progressive. The one I'm most familiar with is the University of South Carolina in Greenville. I featured that medical school in my documentary, Code Blue. And the reason I featured them is because this is a medical school that was built on the principles of lifestyle medicine. The founding dean there, it was his initiative to assure that he built a school that this was incorporated into their education throughout the 4 years. So
I have a question. How can you see this documentary?
yeah, so we're on several platforms like Apple, Google. Our website is codebluedoc.com, and there are several platforms on which you could watch the film. Prime, Amazon Prime. Yes, sir.
A lot of people question lifestyle medicine, but really have to do it. There's so many people can smoke and eat all they want and don't get sick.
Yeah.
And they tell but then there's this group of people who are very sensitive to cigarettes, very sensitive
Yeah.
to meat
Yeah.
and poor diet, and and the addiction that goes with this. How do you talk to some of these people that are just they're out there and just say, well, I'm fine, I don't have any problems, I like what I like American food, I like the diet, and I'm addicted to it and I can't stop.
Yeah.
So-
Well, I think that's the exception to the rule. Yeah, you're always going to find that 102-year-old that smokes 3 packs a day and is just fine. But let's be honest, that doesn't happen very often. And and it's not just heart disease and diabetes. It's Alzheimer's disease. It's malignancies. There's so many, and just not feeling well, not having stamina, and we want to be 85-year-olds that can get up and go, right? Your quality of life is everything.
And it takes time to see the effects.
It takes time. That's the other thing. That's a great point, because unfortunately in our culture here in the United States, we want the quick fix. We want everything to happen tomorrow. I've had patients call me up and say, well, I've been doing this for 2 weeks. How come things haven't changed? When I show that image of myself with the crutch and the cane, and then the finish line at the marathon, that was 7 years. People don't realize that, it took that long, and there were failures in between and
Do you
struggles.
ever cheat on your diet now? And what did you experience if you did?
Yeah, I'm not, yes. We were talking, Dr. Walker and I, she and I enjoy a donut. We do. And it's okay, Dr. Walker. Of course. But, primarily, most of the time, it's really good choices that I'm making.
You ever find when you do cheat, you feel
Well, I never cheat so significant. I don't have 13 donuts. I just have one on
you
occasion.
get into the pizza and
Yeah.
the bread and things
Yeah.
like that. And then
Yeah,
you feel
pizza's not terrible, but I don't sit and eat an entire pie, right? I'll eat a slice of pizza and a big, beautiful green salad with lots of veggies in it. So, I'm partnering it with that. You want to have fun. Food is one of our great, who doesn't love to eat and to enjoy a beautiful meal? Choose the things that you love, and make better decisions. What could you do today that's slightly better than yesterday? Make small changes, and before you know it, you start to realize that these changes, you just feel better. I mean, I was a person who was like drowning in fatigue, drowning in, I couldn't feel my legs for like a decade of my life. So the fact that here I am, it's going to be nearly 30 years living with this disease, and I'm here feeling well. That's a gift. I think everybody's hungry and wants to go eat. Yes? No.
I just wanted your opinion on something.
Sure?
So, with the way that things
Look at what she's doing. I can't even move.
and high costs of things like medication,
I'm not doing
do you feel that there's
it.
purposeful misinformation or lack of information on stuff like that
So we don't become
in order to influence higher sales or costs?
Mm. Yeah. Yeah. Oh, go ahead.
Yes, so the question, I'm sorry, there's an online audience as well, so if you don't mind to come to the microphone for a question, and if I don't do it justice, please repeat. But your question was, or what are your comments in response to the question of purposeful misinformation
What do I have to do to
regarding
get her?
nutrition?
Look at all the energy we're
Yeah, well, I'd like to think that that's not the case. I think we're quick to write prescriptions. I mean, medications are incredibly important. Again, I'm an HIV/AIDS doctor. I grew up in that era. We took a disease that was a death sentence, and it's now a chronic disease. And we did that with the development of these, highly active antiretrovirals that changed the course of this illness. So, and I worked for a pharmaceutical company at one point in my life, helping to develop drugs in HIV and in hepatitis, and I'm really proud of that work. Medications are an important part of our armamentarium to address the disease state, but we need to prevent first. I mean, if you could prevent a disease, that's where you really want to place emphasis. Once we have the disease, then yes, we need to have the tools to serve that patient, to relieve them of any pain or suffering, and to potentially reverse the disease or improve their outcomes. I think, regrettably, because this idea of lifestyle medicine and prevention, it's not profitable, right? So yes, at the end of the day, we tend to not invest a lot in this aspect. But then again, that goes to the first question the gentleman asked. We need to find an economic model that serves this, that values this, so that we can move forward, and it will serve all of us. Thank you.
You are all each invited to share dinner with us. We have a plant-based diet dinner out in the lobby, and we invite you to get to know one another. I'm sure that Dr. Stanzik will be available if you'd like to have individual conversations. And thank you again for coming to Geisinger Commonwealth School of Medicine.